Hey everybody, today I'm going to talk about nurse-patient ratio at the hospital, specifically per floor per unit. We'll talk a little bit about that so that maybe you're a student nurse and you're trying to figure out what floor of the hospital that you want to work on, or maybe you're a nurse that works in the hospital and you want to go to another floor, or you want to get a job in the hospital but you don't know what each unit is like or what to expect. So that's what I'm going to be talking about in this video today. So let's start with the ER. The ER, and now I live in Florida, so this varies throughout the country, varies throughout hospital, but this is just like a general, based on my experience or based on other nurses that I know that I've worked with, and so on. Of course, it's going to vary, so if yours is a little different, then, that's what it is. But this is just to give you a general idea. So starting in the ER, it's usually like 1 to 3, 1 to 3 ratio, so 3 patients. I've heard it can go up to 4 or 5, depending. So to work in the ER, you want to be good with IVs. It's more of like a treat 'em and street 'em. That's what I like to call it. You do your thing, you get them stabilized, and they go home. Bye. So you're not going to grow a relationship. If that's something that you want, then ER is probably not the best place for you, because you're not going to generally build a relationship over time. Some nurses don't want to do that. So if you like that, ER is maybe for you. So treat them and street them. You're not going to follow these patients. Be able to prioritize and triage well. You'll see all ages, so keep that in mind. If you don't want to do peds, then ER is probably not for you, because you're going to see kids, you're going to see babies, you're going to see toddlers, you're going to see kids, you're going to see elderly, you're going to see everything. So if you don't want to do kids, then don't do the ER. You also have to be okay with seeing trauma, because you're going to see trauma, you're going to have trauma patients, so you have to keep that in mind when working in the ER. So they're going to come in, and some of them come in like destroyed. I mean, some of them are like burned, and some of them are like disfigured, from a car crash, crazy stuff. You don't know what you're going to see. So be okay with that. Be okay with, doing critical care, learning critical care and critical patients, stuff like that. Then in a unit like this, you're not going to have generally as much of like ADLs, personal care, bed baths, changing briefs and stuff like that. You will get elderly from nursing homes that go to the ER sometimes, but it's not going to be as much as you might see on other units. So you can kind of bet for that. So you have to kind of base that on what you like and what kind of a nurse you are, because we're not all created equal. We're not all the same. We don't like all the same things. Believe it or not, some of us don't really like people as much. Some of us want that relationship, some of us don't. Some of us are just like, hey, let's do our thing and on to the next one. So next one is ICU. If you work in the ICU, that's going to be a 1-to-1 or 1-to-2 sometimes, depending on the hospital, depending on how many nurses you have, depending on shortages and whatever, but generally 1-to-1 or 1-to-2 patient ratio. Many patients in the ICU are not conscious. Many of them are not awake, many of them are intubated, so you have to be okay with suctioning, be okay with trachs, be okay with people being intubated, be okay with doing lots of drips, and also be okay with lots of ADLs and personal care. You're going to be doing everything for the patient. You don't get a CNA generally or an aide, so you're going to be bathing them, you're going to be changing them, they're going to be changing the briefs, and you're going to be catheters and drips and lots of stuff going on. Hourly documentation, vitals. It's a lot of work. Even though it's 1 or 2 patients, it's still a lot of work. So Don't get it twisted. Like, oh, it's one patient, it's not a big deal. But some people like it because some of them are there for a long time. You probably will grow a relationship, even if the patient is not awake. You're still probably going to grow a relationship with them because they don't have to be awake necessarily, because you still grow close to them because you're doing everything for them, you're caring for them in a very intimate way. So if that's something that you like, then you might like the ICU, you know. But it can also be kind of distressing. I remember working up there, and it just really freaked me out, kind of. I don't know, I just saw a lot of people suffering, and I don't like that. I don't like to see the suffering. It disturbed me. It really like got me. Like, I would see patients that would remind me of like my dad or somebody, and it just really got to me. So if that gets to you, maybe it's not a place for you. And you probably won't see kids in the ICU, because usually they have a PICU and a NICU. You know, they have pediatric ICU, neonatal ICU. So, you know, you're not going to work with kids generally. So if you don't want to work with kids, then that's something to keep in mind, because not everybody wants to work with kids. So next one is pre-op and PACU. You're going to usually have a 1-to-1, 1-to-2 ratio, also a very low nurse-to-patient ratio in PACU or pre-op. Patients are in and out, so this is another unit that it's treat 'em and street 'em. So if that's what you like, they're in, they're out, bye-bye. You know, like you get to know, you don't follow them for a long time, you don't get to know them like that. It's just a quick, you know, start their IV, get them ready for surgery, get their consent sign and pre-op, all of that stuff. You know, talk to the family, do instructions, blah, blah, blah. And then they go into the OR, and then if you're doing recovery as well in PACU, the same, you know, pain control, symptom control, nausea, vomiting. The patient is out of it. When they come out of surgery, they ask you the same question over and over again. I always thought it was funny. I always used to mess with them. They used to say, did everything go okay? And I'd be like, you woke up, didn't you? So, you know, yeah, so I don't know. For me, it was fun. I liked it. I loved PACU. It was good. So, but yeah, so no patient-nurse relationship. You know, yeah, pretty much. Yeah, they're kind of too doped up to conversate too much. They're kind of out of it. Sorry about my birds. So yeah, that one. Oh, and you have to be good at IVs. Have to be good at IVs as well. So keep that in mind. So the next one is OR circulator. So the circulator, you're gonna pretty much have almost no interaction with the patient. So if you're okay with that, there you go. Patient is asleep. The only interaction you have is to wheel them into the OR and tell them to, you know, relax and count backwards. Usually even the anesthesiologist does that, or the nurse anesthetist. Yeah, you're gonna minimal interaction. You try to calm their nerves a little bit, because sometimes they're nervous and stuff like that. Thing that sucks about the OR is you don't get too many breaks. You have to break whenever the surgeon wants to take a break, and that can be a long time sometimes. You can't just be like, hey, I'm gonna go take my lunch and I'll be back, you know. Sometimes you have another circulator that goes around and gives breaks, but you can't go when you want. You have to wait until they come relieve you, and that can be a mess sometimes, depending where you work. You can't just go to the bathroom when you want. And when I did it, I had to go between cases. And if you were with somebody who did quick cases, then that was good, because after you go to the bathroom before you go in, and then you go to the bathroom after you come out immediately. So you just make sure, or you try to grab a quick snack and scarf something down quickly. But if you had one of those surgeons that was like, he just messed around and he was very slow and he didn't care how long he was in there, and then I remember we had one that would actually stop in the middle of surgery, go out in like the dictation area and like sit there and eat pizza and talk on the phone. I'm not even kidding. This really happened. And the patient is like open on the table and we're all just standing around like, right. So yeah. So you never know. You got to do everything to the surgeon's preference. You have to learn your surgeons, learn their preferences and what they like, what they don't like. Make sure you have everything set up according to that. Sorry, my birds are being really loud. Hey, where are you? Anyway, so yeah, so that's another thing. Patients are asleep, and then be okay with seeing blood, bones, open abdomens. Be okay with the sights, smells, and sounds of the OR. So yeah. So the next one is PACU. No, PCU, not PACU. That's what we just talked about. Yeah, the next one is PCU. That's like a step-down unit. It's like ICU step-down. PCU or IMCU, whichever one. That's a 1 to 4 or 5 patient ratio, depending. Like I said, more like a step-down unit. You generally don't get kids. You need more like critical care skills. You get patients with like BiPAPs, trachs, drips. It's critical. It's still critical care. It's like critical care unit. It's like a step down. So, but you may get overflow of med-surg patients and like other stuff like that. Could still be a little bit stressful. You don't need to be like super great with IVs because they come with an IV already. But if the patient is there longer than 3 days, you have to change the IV, or 72 hours. You already know. Well, maybe you don't know, but that's what it is. That's a standard. Every 72 hours, we would change the IV. So, your skills for that don't have to be like super great. But you get like wound vacs, and you get a lot of stuff. You learn a lot of stuff on there on PCU. But it can be a little stressful. And you can grow a relationship with the patient, because some of them are there for a while. Some of them are there for 3 or 4 days. Some of them are there for a lot longer. It just depends. But you generally will grow a relationship with the patient. It can be a good thing with a nice patient. When you get a really difficult patient, not as great, because you're going to see them over and over again. Versus some other units that are treat 'em and treat 'em. So if you get a really difficult patient, they're like done and they're ready to go. So the next one is med-surg. You have usually a patient ratio of 1 to 6 or 7. So I've heard of more sometimes. Maybe you can believe it. I don't know. I've read about nurses saying they had like 10 patients or 12 patients. Oh my God, that would be nuts. That'd be a nightmare. But I've heard of things. Let me know if you've heard of things or experienced things like that. So they say it's the worst floor to work. I haven't worked med-surg, but from what I hear from everybody, it's no good. Everybody I know, the nurses I know, don't like it. High patient-nurse ratio, lots of diversity and skill set. You got to know how to do a lot of things. You can get lots of infectious stuff versus, some other floors where you're not going to get infectious stuff. Generally, like pre-op and PACU, you're not going to have COVID patient. You're not going to have TB patients, because you can't be sick. You can't be infectious when you're going to surgery. So that's one thing to keep in mind. But yeah, med-surg, you're going to get all kinds of stuff. What can I say? It's just not my cup of tea. It's not a lot of people's cup of tea. And you're generally not going to get kids, because you have a pediatric floor for kids. So that's something to consider. The next one is L&D, labor and delivery. You're usually going to have a 1 to 2 patient ratio in L&D. No sick patients, no infectious patients on L&D, because you're not, you don't want to get the baby sick. You don't want to get a newborn with an infection. You don't want to get mom with an infection, so you're generally not going to have that either. So no infectious patients. It's more clean, that's what they call it, like a more clean type of nursing. No overflow. You're not going to get a med-surg patient on an L&D floor, so you don't have to worry about that. You're going to deliver babies, but you're not going to get kids, like pediatric kids on your floor. It's going to pretty much be what you've got all the time. Continuous monitoring of mom and baby, and then mothers don't stay long. They're kind of in and out. They give birth, boom, and then they go to mother baby unit. Bye bye. You know what I'm saying? I always liked that. I like L&D. I always thought that was a cool place to work. So, and you do get like some critical care too sometimes, so it can be exciting if you like that. So the next one, of course, is mother baby. I believe it's 1 to 4. When I did it, it was 1 to 4, and again, no like infectious sick patients, more of like a clean unit, but lots of pain control, bleeding control, peri pads and stuff like that, counting wet diapers and stuff like that with the babies. Lots of discharges. Mom doesn't stay long generally. She's kind of in and out, and bye-bye. So stuff like that. You're not going to grow like a long relationship with the patient and mother baby or an L&D. So the next one is NICU. And NICU, again, that's more of like an ICU, obviously for babies. So it's 1 to 2, or 1 to 1 on the NICU. And you're going to be working with tubes, trachs, and but it's much cleaner than a regular ICU, I feel like. When I did my rotation in there, I liked it. Sometimes it's hard though for people. They see the babies and it's hard for them. It's like they know. Paper Lulu! Stop it! Sorry about my birds. So trachs, tubes, much cleaner. You do everything for the baby. You feed the baby, bathe the baby, change the baby, just like you would in a big ICU, but it's a much smaller little person, Some people have a hard time seeing sick babies, so if that's going to bother you a lot, then you shouldn't do it. And of course, it's not like you grow like a relationship like mentally with the baby because you can't talk to the baby, but emotionally, I feel like you can get attached. I liked it though. It didn't bother me, but for some people, they just can't. They just can't tolerate it. They can't do it. And you may follow these patients for a while, so you may get emotionally attached to the baby. You might. I remember taking care of a little one. It was like she was like a drug addicted born baby, and she was so like, she cried a lot and stuff, and you get so sweet. You get to like rock the babies, and you get to like comfort them. I don't know. I liked that about it, but that's just me. And then let's see, and then the last one would be like pediatrics. So if you have a thing for working with kids and you like working with kids and that's your thing, because it has to be your thing to do it. If you don't like it, if you don't like working with kids, don't work pediatrics. I want to say it was like a 1 to 4, 1 to 3 patient ratio when I did my rotation through there. Yeah, and that was tough. I have no interest in working with kids in pediatrics. It was hard because when they're babies, it's like they're babies. Babies cry, you can comfort them. But when they're kids, when they're older, I feel like it's a lot harder to see them suffering. And it's not like working with kids like, yeah, I love kids. No, these are sick kids. These are kids that are crying. These are kids that are in pain. These are kids that are suffering. Kids with cancer. Kids with... I don't want to see that. I don't want to work with that. That's too heartbreaking for me. You know what I mean? So if you can't do that, if that bothers you, then you shouldn't do peds. So, and you gotta put an IV in a child, and I mean they're fighting and screaming, and you know, it's and then the medication dosing is completely different, so that always freaked me out too with kids, like, because the doses are not the same as with adults. So that's another thing to keep in mind with kids. You know, so those are the main things with all the hospital floors, just general. You know, there's other specialty units and stuff like that, but this is just a general list, and you get a general idea of how many patients you'll have, things that you'll expect, you know, you can expect working on that floor that you may not have thought of, and to kind of maybe help you figure it out if you want to work in the hospital, if you want to do one of those floors. So I hope you enjoyed this video. Give it a like and subscribe if you want more videos about nursing, nursing jobs, nursing students, going to nursing school, you know, caring for patients with different disease process and things like that, and tips for working as a nurse. All right, thanks. Bye.